Hello and welcome to the BHF Data Science Centre monthly webinar. I'm Jackie MacArthur, a Scientific Programme Manager at the BHF Data Science Centre. This month's webinar is entitled Smartphone and Wearable Data for Cardiovascular Research. I'm pleased to be joined today by Professor Tim Chico, Associate Director and Smartphone and Wearable Theme Leader from the BHF Data Science Centre. Today, Tim will discuss the potential of smartphone and wearable data linked to healthcare data in cardiovascular research. He'll also be talking about the challenges involved and how the BHF Data Science Centre is addressing these. He'll present findings from our recent surveys that looked at what researchers believe is the most important smartphone and wearable data to collect, and public views on the acceptability of sharing this data. As a reminder, in case anybody missed it, please could you keep your camera and microphone switched off, and this webinar will be recorded. We'll have time at the end of Tim's talk for questions and discussion, so please post any questions you have into the Q&A or chat, and we will do our best to answer those at the end of the session. If you would like to present at one of our future webinars, please do get in touch with the BHF Data Science Centre via our email address. But now I will pass it over to Tim.
Thank you so much, Jackie. I hope you can hear me. It's a pleasure to talk. So this is a talk for researchers and people interested in researchers, but it's not a research talk. It is an attempt to begin to discuss what we in the theme have been doing and how we feel we can best support the community. If you feel this is not a good way to support the community, now would be an excellent time to tell me in whichever format you feel most comfortable, because it's really important that our work supports the widest number of people as we move forward with our plans. So that's why I'm really excited and slightly nervous to describe where we're at, so that you have the opportunity to provide feedback and perhaps nudge as appropriate in what you think is the right direction. So our funding comes from the British Heart Foundation, and it's a pleasure to see colleagues from the BHF on the call. And so we're funded by the British Heart Foundation, and the British Heart Foundation are funded by people who help them with their mission to research cures and treatments. And I'm going to keep that in the forefront of our minds today to kind of focus what we do. Now, as a cardiologist, treatments often look like this, rather than anything digital. We've seen huge advances in how we prevent and treat a whole range of heart diseases using either small molecule drugs or newer pharmaceuticals or interventions or surgery. And of course, smartphones and wearables aren't any of this. So how are we going to improve using data? And that will be kind of the first part of the talk. And again, it's important for me to get your comments and views on this and how I see it. So doctors work pretty much like funnels. We take in a lot of different types of information, a huge amount of information, even at the moment. And we actually boil that down into a very small number of specific outputs, which are decisions. Quite often we're trying to predict what will happen. So will someone go on to have a heart attack or a stroke, for example? We try and diagnose what someone has at the moment. And we also try and predict what's the right treatment for someone, which is another way of saying we try and predict what would be the outcomes with or without a whole range of potential treatments. So what we do is we take in a lot of information and boil it down into this very narrow set of outputs. And medical data is, I think, the best example of really multimodal data from all kinds of different sources in all kinds of types. And at the moment, we deal with a lot of this. So that's someone's medical history, which is often categorical data. Someone does or doesn't have diabetes. They have or haven't had a stroke. There's continuous data in lots of different forms from lab tests. There's demographic data. And there's really complex imaging data. And this is all the kind of data that we deal with already in the NHS. And this is clearly very valuable. We couldn't do our job without this kind of information. But we know it only provides a very incomplete view of someone's health. There's an easy test for that, which is the same person with the same data seen by two different clinicians will often get two different diagnoses. They'll get two different treatment plans because we really don't have enough information to be precise in our decision making. Now, it's reasonable to hope that if we had more information on someone's activity, whether that be levels of physical activity or how often they get out of the house or who they see, their physiology, rather than just occasionally measuring blood pressure, heart rate, ECG in clinic, whether we had this continuously, potentially over months or years, their symptoms, not just taken retrospectively from memory, but perhaps recorded contemporaneously over time, but also someone's environment. It's reasonable to believe that this would allow us not a complete picture. I haven't mentioned genomics, I haven't mentioned omics, but certainly a more complete picture of someone's health that might allow us to make better medical decisions. And it just so happens that the devices that most of us are already carrying around have the capacity to obtain all this data. But to be fair, are being used for little or no medical benefit at the moment. So I think there's two broad patterns of studies where this kind of data could lead to better treatments and improved outcomes. The first, and there's a lot of work in this already, is in the context of a clinical trial, and a prototypic study design would be people randomized to a treatment or placebo or other intervention. Now, in these kind of studies, smartphones and wearables can be used in both groups to assess the outcomes, to see whether or not the treatment leads to a better outcome than if you're on placebo. And there's lots of work in this area, and clearly this has the ability to improve our ability to understand what the effects of treatments are and discover new ways to improve outcomes. But there's a different model of study where the data itself becomes the intervention. So people with the same condition, they either do have the data or they don't have the data. And then we can work out whether or not the presence of this data in association with all the other data that we have in the medical record leads to a better outcome by improving decisions. And there's three outcomes: decision, prediction, and treatment selection. And of course, there's lots of different heart diseases, and there's lots of different types of populations that this could be applied to. So you can kind of randomly generate lots of different research questions. For example, could smartphone and wearable data improve our ability to predict future risk of a heart attack? Could it improve diagnosis of heart failure? Could it indicate who would benefit most from heart valve replacement? And you could probably generate 30 to 40 research questions, all of which would be entirely reasonable to test using this approach. So one of the questions we had to address in devising the strategy of the theme, which I'm soliciting your input to, is whether or not we focus on specific projects or whether we develop a generic infrastructure which can support ideally many, if not most, types of project. And I suppose to jump to the punchline, generic is the way that we feel is the right way to go. Because if we have a patient or groups of patients and we have their NHS data, their healthcare data, and they have smartphone wearable data, well, if they have disease compared to people without disease, that allows us to begin to understand diagnostic signatures that could be useful clinically. Of course, the same people after a diagnosis will undergo treatment. And if we follow them over time, we'll be able to understand what the response to treatment is, to begin to understand how we might more precisely target treatment or avoid treatment in people who don't benefit. But then over time, in people who are at risk of an outcome, and of course we're all at risk of an outcome, if we follow people for long enough, that will allow us to begin to understand whether we can predict future events. Now, with the BHF Data Science Centre, we're funded by the BHF. We focus on cardiovascular disease, and there's a good reason to focus on cardiovascular disease because the types of data are eminently and plausibly linked with cardiovascular disease. But this is the kind of infrastructure that could be applied to a whole range of both cardiovascular but also non-cardiovascular diseases. And it would be somewhat wasteful to establish it for a focused research study with a single research question when it could be applied to many. So our first report from the theme, which was released before I joined as Associate Director, but I wholeheartedly agree with, is that we should be moving towards a situation where we have a UK-based large-scale research collection of wearable, but also smartphone data linked to NHS data. And in the longer term, I think the success of our theme should be judged as to whether or not we manage to achieve this. So another question we had to address is whether or not this data would come from non-consented or consented participants. Now, that may feel like a no-brainer, but let me just explain why I'm raising it here. So this is the dashboard from the trusted research environment set up by other colleagues in the Data Science Centre, with huge numbers of NHS data sets all linked together at individual level. And of course, there's now a wide range of really important and impactful research being performed with these data sets. It does not include all NHS data. There are certainly holes. There's no imaging data yet, the lab test data, etc. But this is really valuable. And if anyone isn't aware, we don't have direct consent from these participants for the basis upon which it can be performed. And as an advantage, it's really representative. It's almost the whole country, other than people who've opted out, for example. So this would be great if we had this. On the other side of things, we have huge amounts of smartphone and wearable data already. So a colleague of mine, Fabio Chiravegna, developed the Active 10 app, which Public Health England used to encourage people to take physical activity. So 900,000 people have downloaded this app and used it to record their physical activity over time, some for long periods of time, others for short periods of time. We have all that data at the moment, but what we don't have is any NHS data to link it to. So we have this huge gulf. We've got all the NHS data on one side. Apple, Garmin, Fitbit, Fabio has loads of smartphone wearable data on the other side, but we really have no way to join these up. And unless we can put them together, it's not very useful for the purposes which we wish to apply it to. Also, of course, we all have our own data, at least theoretically, and the only mechanism that we can realistically join these up is by prospectively obtaining consent. So I'm afraid if you came here hoping that I would be able to point you to a link which had all this data already, I'm afraid we don't. So we need to prospectively develop a cohort of participants who have given consent to access their smartphone and wearable data, link it to their NHS record, and follow them up. This number has not been subject to formal power calculations, but it's a reasonable estimate that we would need between 50,000 to 500,000 people for it to begin to be a useful resource for the population, for the community. So, I think we need to bear this in mind. We need a lot of people, and that's going to inform the practicalities of how we design our cohorts. So if we need consent, then we also run up against the difficulty of recruiting a suitably representative and diverse population. And we've been given a lot of thought as to how we can try to avoid recruiting too narrow, too non-representative a group of participants, given all the issues that we are aware of in terms of accessing groups that are underserved by research, that historically have been less well represented in prospective consented studies. So for the last bit of the talk, I'm just going to go over our answers to a few questions. The first, of course, we need to design, collect. How would we link it to the NHS data that exists on all of us already? How would we preserve privacy and security? And how would we make best use of the data? So to deal with the first one, we can't just say we want to collect all the data. We have to specify what we are going to do because it needs consent, it needs ethics approval, etc. Now, just to go through some technicalities, there's passive and active data that comes from these devices. Passive data, you just at most wear or carry the device and then it automatically obtains data. So you shouldn't really need any user input. other than perhaps charging it, of course, and wearing it. So examples of this would be heart rate from a wearable, motion from a watch, GPS location from either, how often you switch it on or off, how often you use apps, what the temperature is ambiently, what an oxygen saturation is from an oximeter, for example. But it's important to remember that there's active data that can be obtained that's often perhaps more useful medically. It does require the user to do something, so filling in buttons, saying things into the microphone, taking photographs, putting things on or off in response to instructions, doing tasks like walking 6 minutes, getting up and down from a chair, etc. So here's some examples. And it would allow us to deliver repeated patient-reported outcome or experience measures, or ask them to do clinical outcome testing. An example here might be blood pressure, might be snapshot heart rate, etc. And there's another kind of consideration that I want to flag particularly, which is GPS, so geolocation. At the moment, I strongly suspect your phone is recording where you are, where you're moving around, and someone's got that data. It's certainly not us at the moment. But this is clearly potentially very sensitive, and we need to tread carefully when we're talking about geolocation. So we need to decide what smartphone and wearable data are we going to collect, at least in the first iteration. This isn't going to be the finished product, but we need to start somewhere. So you ask researchers, and of course they say they want everything, but that's not enough to go on. We have to have a balance between what researchers want and what participants accept. And as Jackie's mentioned, we've been beginning to explore that. I'm very grateful to a number of clinicians and researchers and a patient, Lawrence, who's on the call, I think, who joined a working group to begin to flesh this out. After a number of discussions, we came up with some draft lists of what the data should be that would be obtained from smartphones and wearables. That had further input from the public advisory group of the Data Science Centre. And the long list that we came up with were, these are passive types of data, so either snapshot heart rate, continuous heart rate, you can see them here. And this is automatic or passive data. This is active data, so it would require someone to enter information, likely into a smartphone app, but some wearable devices allow you to enter things onto the watch. And of course, GPS location. And there's a whole range of different measurements that you can calculate if you have someone's GPS location. Here's some of them. And we did 2 surveys, one with the public and one with researchers and clinicians. And if any of you on the call took part in the professional survey, I'm very grateful. It was very useful. We had 56 respondents from the research community and 194 public and patients. And of course, there was data that no one wanted to collect and no one found acceptable. But what's most interesting is the things that are most acceptable and most important. So importance is rated by clinicians and researchers on the left axis, the y-axis, and what's acceptable to potential participants, the patients and the public. Most useful or most important to researchers and most acceptable to patients and the public is continuous heart rate. Now that's very useful to know because there are no phone-based approaches that you can use to continuously measure heart rate. That has to be a wearable to be obtained. Moderate activity, vigorous activity, well, that can be obtained by both wearables and phones. Time spent sedentary, again, either device can measure this. ECG parameters unlikely to be measured by a phone with current capability, for example. So this gives us a starting point to begin to design the specifics of a prospective collection. So we know that we need phones and we know that we need watches. And one of the kind of questions we really need to resolve is, do we only recruit people who own the devices already, or do we provide the device? Clearly, there's advantages and disadvantages to either approach. And this is in the backdrop of the fact that almost everyone, at least 90% of the population now, own a mobile phone. And it's evenly distributed, relatively speaking, between people in the lowest and the highest income bracket. So a study using phones can expect to be reasonably representative. Of course, there's many other details there, like data package, processor speed, memory, etc. But broadly speaking, phone ownership is relatively equal across demographic groups. And this is the same across geographies and across ethnic groups. Completely different when it comes to smartwatch wearable type devices. Very few people in the lowest income groups have these devices compared to the most affluent groups. And so in terms of designing cohort studies, we think that an infrastructure that requires phone ownership could at least be representative if done well and is justifiable based on current device ownership rates, which are slowly increasing further. But an infrastructure that only recruits wearable owners will be unrepresentative. And so we are keen to avoid study designs that require this, at least as the entirety of a study. So just as an example of how we're beginning to approach this, because you can't give the whole population a device, but we have worked with Google Health and Fitbit on a project, and we are going to approach Fitbit owners, so these are people who have already bought their devices, via the Fitbit app to direct them to a study where they can sign up. So that's recruiting people who already own devices. But to try and increase our ability to recruit a diverse and representative group, a first tranche of 500 devices will be provided by Fitbit for free, that we can provide to people who would like to take part but don't have a qualifying device. And this seems to be a reasonable compromise between costs of studies and equity and representativeness. So assuming we can obtain this data, how do we link it to NHS data? Well, I've already shown you this data, and this is what we would really like to be able to link our smartphone and wearable data to. Clearly, this can't be done in the current TRE, but the mechanism would be to obtain the NHS number for that linkage. In a pump priming project with Richard, Amos, Alan, and Fabio, we have developed a smartphone app. It doesn't really matter about the app, but what it does is it provides the relevant participant information to allow them to obtain their NHS number from the NHS lookup service and then link that to NHS data using an appropriate range of identifiable details. So we have a front end that can be used for this linkage. If we're proposing, which we are, to obtain all this information on someone's location and health and NHS data, then clearly that's incredibly private and sensitive information, and we need to be careful about how we preserve privacy and security. I won't labour this point, other than we have many experts on the call who've already managed to achieve this with existing infrastructure, and clearly the 5 safes would apply for access to this information. Unfortunately, the cohorts theme led by Reacher in the Data Science Centre is already establishing a trusted research environment with all the necessary safeguards where cohorts of information, including smartphone and wearable data, could be brought in and then linked with NHS data. So that's going to hugely support this work. So how do we make best use of the data? It's going to take quite a lot of time to accumulate enough information. And what I'm going to outline now in just the final slide is how we think this might work. And as I say, your input would be really valuable. So we're going to start with some driver projects. Fitbit is just a case for discussion. I'm not trying to advertise any particular device, but take the example I've outlined. We'll approach Fitbit users, we'll give some Fitbit devices out, we'll obtain the data which is outlined in our surveys. So that's one study. We'd also like to find other driver studies which are recruiting their own participants that are using smartphone and wearable data, perhaps other devices, perhaps other apps. Ideally, we can work together to make that data as generic and interoperable as possible, accepting that some studies will want specific data that other studies do not. And then there may be other research studies who don't have an app, they don't have wearables, but are keen to begin to acquire this data. And we'd like to provide a customizable and particularly important, are cost-effective to the funder and research groups, no code, smartphone and wearable data platform. This means that you don't have to interact with very expensive software engineers to develop your own app, but that you can take it off the shelf, design it using no real software skills, and then release it to your study participants. We would then obtain consent to take this data into the trusted research environment led by the cohorts theme, where it would be linked with NHS data, initially nationally held data sets, but eventually we'd like to try to access other data sets like the imaging data and the lab data, which currently is held more locally. Now, initially, the data wouldn't leave the TRE, the driver projects, as they are allowed to link to the NHS data to follow up patients. But in the longer term, once we've accumulated enough data, even researchers who do not have their own research cohorts could access the TRE using the 5 safes to try and test research questions using the data accumulated in this infrastructure. So I'm very grateful to everyone who supported this, particularly Jackie, but also Kathy, Lynn, and the whole Data Science Centre team, with the working group members are listed there. The public patient panel have been critical in all of this. Sue Thomas has been very supportive from Google Health and Fitbit. Richard Amos and Alan are supporting the app development, and the EPSRC Digital Health Hub that I lead. We're building this at a local level to learn how to scale it up nationally. So thank you very much for your attention, and I'm very grateful for your thoughts and advice.
Brilliant. Thank you, Tim. That was a great outline of our work and our plans moving forwards. So if you've got any questions, please do post them in the chat or raise your hand and we'll get to you. So I see Peter Charlton has posted a question in the chat, so I'll get to that one first. So Peter asks if there's any considerations have been given so far to collecting and using process data, for example, heart rates collected by device versus raw data, for example, raw ECG, or I'm not going to pronounce that word. You might be able, you might know.
PPG. No, I always say PPG. Peter, it's absolutely critical question, and I'd be grateful for your thoughts. I guess there's a couple of things. Of course, the researchers, all of us, want all the raw data. The more raw data we have, the less interoperable it is across different devices. And I'm not sure if I made it clear enough, but we're talking about a platform that takes device data from hopefully as many, if not all, data devices as possible, and also smartphone devices as possible. And there's also storage and linkage issues in terms of storing the raw data and linking it to all the NHS data. That is now my advice is variable as to whether or not that is truly a difficult analysis and storage challenge versus linking more processed data. I have to say, clinically, I probably couldn't cope with more than one number per day per person, particularly over months. So, for example, mean heart rate, maximum heart rate, SpO2, etc. So I think what we'll probably move towards is a storage container for the raw data where we can get it, because of course quite a lot of the raw data is processed on device and isn't easily accessible to the researcher, but then extraction of as many interoperable process metrics as possible, and it's that would be linked to the NHS data, at least initially, but I'd be keen to discuss with colleagues.
Brilliant, thanks. So there's another question that's been posted in the Q&A that I'll read out. So you presented some smartphone and wearable stats by affluence. Do you have an idea of the breakdown by age or the age with affluence interaction?
Yes, I have. And if you contact me afterwards, I can send you the surveys that it's come from. Age falls off a little bit, but not too much in terms of smartphone ownership. Wearables are much more skewed towards the young. Does that answer the question? But if you get, I'm keen to share the surveys. There's a huge amount of data out there on this, and it's because it changes every year. The survey that I've presented is performed every year by in fact, a consultancy. So.
Great, thanks. Yeah, we have this, as Tim mentioned, there's a huge amount of stats on that. So yeah, it depends how you want to see it, but please do get in touch if you're interested in finding out more information on that. We're having quite a few questions coming in now, Tim. So okay, so there's a question on how are you planning to roll this out and publicize the project so that people can apply to enroll, and referring to the Fitbit project in particular, what if you don't own a Fitbit?
So there's you need a different logistic model if you're giving out devices versus if you're just recruiting online remotely, because one of the advantages of an approach where you link phone and wearable data to NHS data is no one needs to turn up to give a genetic or another sample. You can potentially do this without any face-to-face interaction, which means it's scalable and can be performed at national level. But if you need to give someone a device, then that needs to be either posted to them or given to them face-to-face, but probably face-to-face because it needs training. So the Fitbit study, and again, that's not anything other than an example for discussion, other than the fact that it is something that I'm running in Sheffield, will be local. And we will give out the devices and training initially, and it will actually be linked to locally held data sets, not NHS data sets, because the cohorts platform isn't up and running yet, but it will work through quite a lot of the practical questions. So that was that. Did that, I think there was a second part of the question, Jackie. Oh.
I think you've covered all of that. Did you mention how people might enroll to, I guess, how people might enroll to the other studies as well as? Yeah.
So, well, I'm very much hoping that's coming from a public member who might be interested in taking part. We're not ready yet, but at some point we will be ready to, in some ways, I would hope, nationally advertise for people to take part. Now, I think the problem with that is, if we're too successful, everything will break because we'll get too much interest at once. So we'll run it in pilot centres, beginning to develop the infrastructure before we make it just widely open. But at some point, it will go onto the App Store, it'll go onto Google Play Store, you'll be able to download it and then sign up and take part in much the same way as really successful projects like Zoe have been run.
Great, thanks. And I'm going to jump to a question that's related to this while we're on this subject. So in terms of companies, for example, Google Health that owns Fitbit, will the companies have access to the data, and will it be shared with other organisations?
So Phil, that's a really great question, and I'm grateful for you asking it so that I can make it very clear. Although Google Health and other industrial partners are partners, they don't want and they can't have the NHS data. So, and the 5 Safes framework is one of the ways that we and other similar organizations are using to control who has access to data. But although it's a partnership with various industrial partners, this is not providing widespread access to NHS data. And of course, what we need to do is make sure that fair value is returned back to the NHS and to the people who participate, ideally in terms of better cardiovascular health.
Brilliant, thank you. Yeah, I'm running through the questions in the order they kind of relate to the next step. So a question here: can researchers feed their data obtained in smaller studies, so I'm assuming that's smaller smartphone and wearable studies, into the BHF Data Science Centre? So
yeah, and that's kind of what I was trying to indicate with that cartoon. Someone's banging on the door to try and get in.
Yeah, I think
so
yes,
we would definitely want that as one of the driver projects, and ideally if we have enough of those projects and we have the appropriate consent and permissions so that the community can access those aggregated together, and that's why the need for interoperability is so pressing, then yeah. And I guess So our service, if you like, to our customers, as in the community, would be, if you have a cohort like that, please contact me and Jackie if you would find it useful to be linked to the routinely collected NHS data for the participants.
Brilliant, thanks. And we've had a few questions and comments about the kind of the quality, validity, kind of detail in the data. So will there be a standardized data format, core outcome slash data set? And how will you ensure interchange with local databases, e.g. for imaging and EMR systems?
Yeah, so I've made it sound really easy. For now, it's really hard. Ideally, and this is the reason to have these conversations now, we should be talking about what a standardized core data set would look like that works for everyone, and that we can layer study specific data on top of, but that we have an eye to later on pooling our data for aggregate analyses. So that's at the smartphone and wearable data. Now, there's a lot of technical issues there in terms of how we, what our interoperability standards would be. There is a need for data standards in this field that isn't currently addressed, and it's something that Jackie and I are talking about, trying to drive forwards. In terms of how it would enable interchange with local databases, well, at the moment we're imagining it would be linked to nationally held data sets that we have more familiarity with dealing with. But in the longer term, the local data sets, the imaging, some really important data sets that we would try and link to. But I guess initially we would be pretty parsimonious. So we wouldn't link with a whole echo, but we might link with the ejection fraction and some kind of descriptive characteristics about valve disease, to take that particular example, just to show that we can do it. And I suspect it would be very valuable, even at a very simple parsimonious level.
Brilliant, thanks. And well, I'll go to one last question, but if you do have additional questions, please do post them or send them in and we'll get to them. So I see another one's just popped up, but talking about the data and the validity and the type of data that we collect, could you comment on the kind of time span of the data, so the merits of short bursts of intense data compared to less data intensity, but more of a longitudinal record? And in terms of longitudinal data, are there any existing data sources that could be mined?
Yeah, that's a great question. So I think as a researcher, you want all the data really intensively being wired up continuously. So the short bursts of intense data are most likely to be best applied to clinical cohorts, people who've got really something to gain. So people who've been proven to have heart failure or recently admitted to hospital. And also, you're more likely to find signals in shorter periods of time from those groups. So that's about cohort selection. In terms of longitudinal records, well, for the reasons I've explained, I think we need to prospectively consent people, which means moving forwards. But one of the advantages, if we consent someone now, we can look back at their historic data with their permission. And so if I recruited a Fitbit user today, I might be able to look at the data that they've had for the last 5 years, if that's how long they've had their device. And so that might give us more of a longitudinal record. So I think you're absolutely right. We need intensities. At the large scale, we want small amounts of data continuously over years, ideally, but then selecting clinical cohorts with more intense data, if that makes sense.
Brilliant. Thanks, Tim, for your presentation and for the answers to the questions. We've had lots of brilliant questions coming in, and we will endeavour to get to all of those. We're saving the chat, and we'll record. We've got a record of all the questions that have been asked, so we can respond to those. I know there's a lot of questions about who will have access to the data, the safeguards in place, that kind of thing, so we can cover that as, in our responses. So I know that there's been in the chat I think Gemma or Hannah have put there won't be a webinar in December, but we'll be back in the new year. So yeah, big thank you to Tim, and thank you to everybody attending and for all your questions.
Thank you. My email's in the chat. Please do get in contact. I'd like to continue the conversations and address some of the questions. Thank you so much for coming.
Thank you. Bye.